So with with us, we are very fortunate to have two people who I very much look up to. One is Dr. Chellani, who has been a great supporter of breastfeeding, and to the extent that sir is one of those people who have given us the IKMC project guidelines, and because of him now we are able to talk to pediatricians about the importance of kangaroo mother care for small babies as well as big babies. Dr. Swati.
Yeah.
Yeah.
So good afternoon, everyone. On behalf of BLK Center for Child Health and IAP Central Delhi, I formally invite you to this BLK Telepeds webinar on failure to thrive in breastfed babies, how lactation support can help. Obviously, breastfeeding is the most important form of nutrition in the first 6 months of baby's life. And to some other infant diets, it comes naturally, while others may face problems. And many times switching to formula appears to be the most easy solution. So lactation support can be of critical help in such situations. So today we will hear from the experts. To chair the session, we have with us Professor Harish Chellani. He is the in charge newborn unit department of pediatrics at Safdarjang Hospital. He has been trained at Harvard School of Public Health, Boston, for improvement of quality of health services. And Sir has played a key role in various government programs in facilitating facility-based IMNCI and facility-based neonatal care, along with in accordance with the Ministry of Family Health and Welfare. And he has also published various national and international journals. It's a pleasure to have you here today with us, sir. Thank you for taking our time. And we have with us Dr. Anita Gupta. Ma'am is a senior obstetrician and gynecologist practicing community obs and gynae. And she has trained several lactation professionals, including Dr. Shacchee, who is the speaker today. And ma'am is also TOTS trainer for IYCF and BFHI courses. A very warm welcome to you, ma'am. And I may kindly request Dr. Anita to introduce our speaker for today, Dr. Shacchee.
So, how to introduce? I've been associated with Shacchee for a very long period, and the amount of passion she has for her infant feeding and breastfeeding, I really appreciate that. And she is a senior consultant, head of lactation services, director clinical lactation internship program. So she's running an internship program also. You can always come and do all internships under her. She's a founder member for, let's see. एक मिनट रुक जाओ. I can't see her presentation actually, ना. जरा उसको करोगे? And she's doing private practice for the last 2 years. And how can I see you? So let's hear what is new, and the topic she is talking about is the failure to thrive, how to tackle them, the children. So,
yes,
so how skilled lactation support can be a help, and that is a really a viral topic for all of our practitioners. So let's have a good listening here to her talk, as she'll be talking very nice and very apt and clear. So, okay, Shacchee?
Yes, ma'am. Thank you so much for your kind words. And it is always a pleasure to have you whenever I'm speaking, because you are my first teacher. When I started learning about lactation, you were the one who got me into this field, I would say. So thank you for that, ma'am, and thank you for being here. So today we are going to discuss when breastfed babies come to the pediatrics clinic and they are not gaining weight. So we commonly label them as failure to thrive, because they are not thriving, and how we can support those diets with skilled lactation support. So although I would be making a case for skilled lactation professionals, but also the main message today is that even pediatricians, if they have the time and skills, it's actually quite simple to support such families. So how the flow of the session would be is I would be briefly touching upon the problem, why we are discussing this topic, and then how breastfeeding works so that we can understand how we can support families better. We would be discussing a couple of cases, and I would also be telling you what kind of lactation support is currently available in India. So where am I coming from? Whatever I'm saying is coming from my experience in my work with breastfeeding diets. I work one-on-one with breastfeeding diets at BLK Hospital, at BLK-MAX Hospital from 2010. And also I work with lactation professionals working across India. And currently we are a team of 250 plus members. So also I would be sharing inputs from lots of lactation professionals and healthcare workers who I had the privilege of working with and who I played a role in their training. So their inputs are also mentioned here. And also I'm privileged to occasionally get a chance to go and see how the things are in public hospitals. So when we talk about the breastfeeding data in India, looking at our NFHS 5 data, if we look at it, and I'm sorry, there is a typo in here, it is not 2029, it is 2021. So looking at our data, if we look at it, I'm not going to go into details, but if we look at it, somewhere around 45 to 65% our rates are varying. They have not changed much over the last many years, in spite of many more lactation professionals available in the country, in spite of there being more awareness about breastfeeding in the country. So what is it that we are lacking? And similarly, if we look at the NFHS data of exclusive breastfeeding, it is very saddening and discouraging to see that from NFHS to 4, some states, some regions have shown a dip in our exclusive breastfeeding rates. So question is, why is it this happening? Is it that we are facing an epidemic of low milk supply, or is it that we are, or like as I commonly hear that families these days don't want to put in effort, moms do not want to put in effort, no one wants to breastfeed. So is it actually like that? My experience and the experience of my fellow lactation professionals says something else. And in all probability, maybe you are also experiencing that families are facing quite a few challenges when they try to breastfeed. So what are the common reasons for early weaning or adding formula, like not exclusively breastfeeding? So many families would come and tell us in OPDs that baby stays dissatisfied, does not matter how much I feed. Babies are having weight gain issues. So pediatricians, their biggest worry is what if the baby is not growing well. So weight gain issues are also a common reason why families are often told to add something else, because the baby is not gaining weight in spite of mother being very motivated and breastfeeding. Like wanting to breastfeed. Then nipple pain and injuries is also very, very common subset why families or mothers specifically decide to add something else. Low milk supply. Often we say that it is perceived, but this perception is so strong because the baby is not thriving. And then obviously addition of top-ups, whether judicious, injudicious, needed or not, also leads to that. So if we want to understand how to support families, we need to first understand how breastfeeding goes. What is the science behind breastfeeding? So it is a good idea to know that it is a cascade. It is a sequence of events. So like the domino effect, if things are going right, they keep on going right. But if the things are not going right, or there are interruptions, or there are obstacles, then again, it's a domino effect where family feels more and more pushed towards addition of other things. So how breastfeeding works, it's actually very simple if we really think about it, because milk production begins in the birthing parent or the mother at around 16 to 18 weeks of pregnancy. Now, milk production has already started, and mothers experience it in the form of darkening of their areola, change in their breast sizes, tenderness in the breast, many such signs. And some mothers, yes, do see let down towards the later half of the pregnancy also, but then darkening of areola is something that we see uniformly, and that's a very good sign of hormones working well. So the moment baby is born and the afterbirths, the placenta is expelled and the baby is put to the breast and baby is suckling efficiently. That is what initiates the series of events for successful breastfeeding. So day 1, day 2, typically baby suckles colostrum from the breast. And by day 3, day 4, there is stage of copious milk production, which the science people know as lactogenesis 2. And thereafter, the more the breasts are suckled efficiently, the more is the nursing, the more is the production, because it is a demand and supply principle on which breastfeeding works. Now, any intervention, Divya, you need to mute your mic, please. Yeah. So any intervention that happens at birth, be it augmentation of labor for the mother or any kind of intervention which causes any pulling, pushing for the baby, they can impact the hormonal milieu as well as baby's reflexes. Because again, for a baby to root, to open his mouth big and to go to the breast, to latch efficiently, baby will need everything intact, right from his nerves, his muscles, to everything. So when we talk about low milk supply, we see it so much. Every single new mother who comes to the OPD has doubts about the milk supply. And so many of them will tell you literally that I feel I have low milk supply because baby is not growing, baby is struggling while feeding. So fortunately, primary insufficiency of breast milk is very less. But yes, the commonest reason why we see a suppression of maternal milk supply, or we see a hampering of release of the parent's milk or the mother's milk, are the common causes like oxytocin inhibition. So when I say oxytocin inhibition, I mean endogenous oxytocin of the parent, which gets inhibited if the parent has received artificial oxytocin like Synto drips, so augmentation of labor. If someone has had traumatic birth, trauma does not necessarily mean pain injury. Trauma can also mean having the kind of birth which you did not anticipate. So all these cause decrease in endogenous oxytocin release, which again is responsible for letdown of milk, maternal behavior, maternal instinct to put the baby on the breast with early signs of hunger. Likewise, delayed initiation of breastfeeding. It could be because of separation, which at times is necessary if the baby is in distress and baby needs to be separated from the mother or is born premature or with any other challenge. And at times it is also because of the practices in the hospitals wherein there is no option of putting the baby on the breast in the recovery or OT. So there is an initial separation if it was an interventional birth. Likewise, judicious or injudicious formula supplementation. Many times it might be a thing wherein the formula or something else is added. But again, the question is, because it was not in the normal sequence of events, it impacts the sequence of breastfeeding negatively. Likewise, if the family does not get correct skill support, like the mom has had an interventional birth, she does not know how to latch on the baby because she's lying flat on the bed. So if there is skill support, they know how to do, what to do. If the mother is lying, how to help her. If she has had a cesarean, how to help her. But if there was no skill support, many times it impacts the latching. If things are not going well, milk is not being withdrawn well from the breast, and as a result, everything gets impacted because, again, of the domino effect. Some causes wherein a mom or a parent can have a lower milk supply or insufficient milk production. The known causes are insufficient glandular tissue or hypoplastic breasts, although these are not exactly same, but for common people, these terms are used interchangeably. And the basic premise is that in the breast, the milk producing glands are less. Similarly, if the placental fragments are not, they have not expelled properly, if there are retained placental fragments, that can be a source of constant pregnancy hormones, and that can also impact the transition to copious milk production. A history of breast surgery, pituitary hemorrhage, heaven forbid, like what we know as Sheehan syndrome, untreated chronic hormonal conditions can all impact milk supply. But if we look at our demographics, thankfully these cases are pretty less. So if everything is as it should be, the baby was born comfortably, birth was fine, it was cool, the baby was put immediately on the breast, this is something that will happen, that baby will go onto the breast, open his mouth, grab the breast well, and would start suckling. This is a slow motion video. A beautiful video at that. So many times we see that things are not going well. We think that the mother is breastfeeding. She says that she is breastfeeding, but actually things are not going well.
As much as we have studied a lot about how good latch looks like, some practical pointers and objective criteria which give us a fairly good idea if the baby is latched correctly and if the baby is transferring milk from the parent's breast into his or her body. They are very helpful in number one, for a clinician to understand how actually things are, and also to help us make the family catch these points. Because if a family is trained in assessing whether breastfeeding is going well or not, they are empowered, they know, they are knowledgeable, and then they are able to pick up very quickly if things are not going well, and they reach out to us for help. So assessing a breastfeed is not very complicated. There are certain telltale signs that will tell us that if the feeding is going well or not, and in those, primarily maternal comfort, as in breastfeeding should be fairly comfortable for the mother, she should not feel any pain or biting, and from baby's aspect, the baby should have age appropriate outputs. We are going to discuss them in the next few slides. And also the baby's weight monitoring should show age appropriate weight changes. Certain red flags: if there is any nipple pain, nipple injury, soreness which continues, if the baby sleeps at breast. When I say sleeps at breast, what I mean is very quickly sleeps at breast. Baby needs constant stimulation to stay alert, to keep on suckling. The baby cries excessively or is excessively sleepy and not even getting up to feed. The baby has low outwards, more importantly, low poop counts, and the baby has either lost excessive weight in the initial few days or the weight gain is slow. These are the red flags, and we'll try and understand them one by one in the next few slides. So I am primarily talking here about the typical age, appropriate for age weight baby who's born full term, but they're applicable to most of the preterms also. So typically when baby feeds and the baby is latched well, mother does not feel gums, because a good latch always has baby's tongue under the breast. So mother's breast do not come in contact with baby's gums. Baby suckles, pauses, suckles on its own. No stimulation is needed. And post breastfeeding, the baby is comfortable, dozes off, gets up at regular intervals to ask for feed, and mother and baby both are comfortable post feed. So mother is also not having any pain or any discomfort. As far as outputs go, initial days when baby is mostly taking colostrum, urine output might be in the range of 1 to 2 per day, or they can be more if the mother has received lots of IV fluids and baby is in diuresis. By day 3, day 4, the urine starts becoming copious. We don't see urate crystals, that is orangish discoloration of the nappies, beyond day 4 of life. And babies are passing many urine outputs by the age of 4-5 days. And if you ask the family, they would say, minute pe potty karta, as in the baby is peeing every few minutes. There is a huge amount of controversy where stool outputs in babies is considered, because many pediatric textbooks say that if a baby is exclusively breastfed, the baby might not pass stools for many days. The research-based evidence shows that it is not correct. And if a baby is well fed and is a baby is latching well, the baby transfers foremilk as well as hind milk and is pooping many times a day. So typically, again, day 1 to 2, baby can pass 1 to 2 or more potties. But by the time the baby is day 4, mother has also come into lactogenesis 2 or stage of copious milk production, baby's output increases. And usually this timeline correlates with transitional stools. A week-old baby typically passes 4 to 5 or more potties in a day. Weight changes, again, in exclusive breastfed babies are something where there are lots of confusions, lots of protocols, but typically speaking, if a baby is losing more than 4% weight in the first 24 hours, that is a sign to look into the latching. That is a sign for referral to someone who's trained in assessing a breastfeed. In 24 to 48 hours, babies again lose weight, but usually typically it is less than 8% of the birth weight. So some centers do take up to 10% as within the range, thinking that because the mother received lots of IV fluids, the babies can be at falsely high level of birth weight. All babies start regaining weight by around day 5 of life. So therein the weight gain starts and they cross their birth weight typically by 10 to 14 days of life. So any baby who has not regained birth weight by second week, by the end of second week, should be carefully assessed for latching and effective milk transfer. And thereafter, once the baby has reached the birth weight, thereafter the well-fed baby will show a weight gain of anywhere between 30 to 50 grams a day in the first 3 months. So we can say roughly 200 to 400 grams per week, and that translates into a lot, I would say 900 to 1500 grams a month. This is a video which we have made in our NICU. And so here the baby, if you notice the chin movements of the baby, the chin is moving deep and slow, and the baby is not needing any stimulation to keep on suckling. So typically the baby will suckle for 10-12 times, take a smaller pause, and then would start suckling again without the need for any stimulation. Now, question is, who's going to do this assessment? Because we all know that wards are fairly busy, and more often than not, it comes to the pediatrician, and the pediatricians say we cannot stand and simply assess the breastfeed for an hour. That's a good point. And if you can, you can have maybe someone who's at a junior level who is helping you with the rounds, or some nursing staff get trained in assessing a breastfeed and they can do it for you. Otherwise, I feel just asking the questions about the pee count, poop count, having a record for that would also be immensely helpful in assessing the breastfeed. So it is quite simple to assess, helps with anticipatory guidance, and also helps with referral. But situation is at ground zero, we all know, is pretty challenging. There are time challenges, there are skill challenges because we don't know how to do all these things. Then there are patient related challenges wherein we have lots of visitors coming in, no time for skin to skin contact and all that. And also some hospitals have a routine protocol of separating all mom babies, some have of separating the cesarean section babies, and lot many issues which can be clubbed under the administrative challenges. So all in all, the bottom line is that most of the families are getting suboptimal support during the time period when they deliver their babies. And many factors, they can have an impact on optimal breastfeeding, like our lifestyles, the way our postures are, the way we carry our babies can impact muscles of the baby, and as a result can impact suckling. The births have become highly medicalized. Moms are getting so many medications, some to induce, some to say, for example, prevent the premature contractions and whatnot. So they are needed many a times, many times these impact the suckling of the baby. Then basic maternal health, any mother who is also undergoing some medical challenge, again that can impact the breastfeeding outcomes. Also in situations where mother has some serious issue, separation also, the chance of separation also increases. So all in all these impact breastfeeding and lactation, because as we saw, it is a sequence of events. It is not just putting the baby on the breast, it is how mother and baby have been working together for breastfeeding from the moment of birth. So if any of you is interested, these are two excellent articles which show the impact of different birth practices on breastfeeding rates. I have given the link for these studies in my resource slide. So what is the common clinical scenario with which families come to us? It is typically babies not gaining weight adequately, or the parent will complain that baby stays at the breast for long feeds, and the moment you put the baby down, the baby is hungry again. My baby is much thinner than his or her formula fed cousin. The baby is not sleeping, or the baby is not getting up to ask for feeding for hours every time. And typically you will find common associations like irritable baby, colicky baby, gassy baby, maternal nipple soreness, and also after a few weeks, maternal supply going down. So what do we do here? Like, for example, let's take a common case. A 4-week old baby, say Chotu, is brought to the OPD. The baby was born at term, 39 plus weeks. Birth weight was 3.2. Now this 4-week-old baby, Chotu, is currently 3.2 with clothes. So that means the baby is even at a lower level than what the baby was at birth. Now, mother is very motivated. She says, I just want to breastfeed, and she is actually only breastfeeding. But she also says that I'm getting exhausted because my baby feeds throughout the day and the night. The baby is passing 10 to 12 urines, again, which from our criteria tell us that the baby is adequately hydrated, and the baby pass stools every alternate day. So if we go by the old teaching that even if a breastfed baby is not passing stools, it's okay, then we might just dismiss this baby and mother saying, oh, these are normal teething troubles and you'll be fine and all that. Or we can think that maybe the milk supply is low. That is why the baby is struggling. But if we look at the criteria that we discussed, the baby is pooping less. That's our first red flag. The baby has not gained weight. That is our second red flag. And the baby keeps feeding. So any baby who's feeding efficiently, why will that baby keep feeding for so long? And now, to add to that, there is stress or pressure from the family. Please add something because the baby looks like he's starving. So what is happening here is baby is breastfeeding for very long. Baby is passing many urines and many stools, but is not gaining weight. So that means that the baby is working so hard to withdraw that milk. The baby is consuming extra energy to withdraw this milk and is also not withdrawing the fatty hind milk. So it would be like you're gymming a lot throughout the day and you're eating fat-free food. So ideally in this kind of scenario, you need a proper latch assessment by a skilled lactation support person and professional if you have someone like that in your team. And also, in the meanwhile, it is very important that this baby gets assistance with express breast milk. The family gets assistance in learning how to express and give, because the baby is underfed, but what is happening in the breast? Because less milk is being withdrawn, so much of the milk stays in the breast that there is secondary suppression. There is a protein in the breast milk called feedback inhibitor of lactation, or FIL, and that causes the feedback loop of suppression of milk supply. So again, those of you who are interested in learning more, there are beautiful Academy of Breastfeeding Medicine protocols. You would be, if you search for ABM protocols, you would be able to see this. And there is a protocol for a baby who is not thriving. So if you come across a baby who has good outputs, if the baby has good outputs, that means baby is getting good amounts of milk. And when I say good output, I mean both urine and stools. I do not mean just urines. So if a baby's outputs are good, then we need to see if the mother is comfortable, baby is comfortable, or if baby is irritable, has sleep issues, has gassiness, all that. So this baby is not gaining weight, but the baby is passing lots of outputs. That means baby is taking out milk, but baby is expending more energy. But if the baby's outputs are also less, that means baby is also getting less. So if baby is feeding well, the baby will be comfortable, the baby will gain weight. But here the baby is not gaining weight. I know it is sounding a little confusing, but simple. If the outputs are also less, it is a more serious thing. If the outputs are there, but the mother and baby are uncomfortable, we need to address the cause. What is happening here? Someone skilled in the art and science of lactation support needs to assess why is it that baby is spending so much time in extracting milk. So both of these scenarios, we will need to assess the latch.
We will need to help the family in understanding how to express milk, because if baby is not withdrawing well, when they withdraw and add, that decreases the baby's work, because now the baby is getting some express milk also. It helps in better drainage of maternal breast, so helps with milk supply also. And also the family needs to be taught how to supplement milk, because again, commonly what happens is parents are told to add either formula, they are not taught about expression, or if they are taught about expression, they are often told to not use bottle. Now visualize the scenario of a new parent who's exhausted, sleep deprived, sore at the breasts, at the nipples, and is trying to katori spoon feed. So there are so many ways wherein parents can be taught how to supplement without using a bottle. There are many ways to do that, and if you Google search it, you'll actually find videos for it. Again, if you have time, excellent. Otherwise, you can have someone from your staff get trained in it and help the families, or you can have a lactation profession on board. And often parents are told to, maybe your milk is deficient, add MCT oil. And yes, I've literally seen prescriptions of MCT oil even with full-term babies. Restricting feeds for 15-20 minutes per breast. So often parents are told restrict. Now baby is taking 1 hour to withdraw some amount of milk. Now this is restricted, things worsen. Don't feed too frequently. Use one breast at a time. Don't use both breasts. Use both breasts. Don't use a feeding bottle. Pumping confusions. So there are so many things that are told to the mother. Again, I acknowledge the fact that everyone is trying to help the family. But actually, are we helping the family? Or are we making the situation more complex by stressing out the parent more? So eventually what happens is original problems stay unaddressed. Parental confidence in breastfeeding is lost. In mother, secondary milk suppression sets in, and it impacts future feeding decisions, because you decided to breastfeed and you're having so many challenges. So next baby, you decide, okay, I'm going to mix feed from the beginning because I do not want to go through that again. So again, a common case scenario, baby gets readmitted to an ICU with excess weight loss. Baby has lost 15-17% weight. The baby is in hypernatremic dehydration, and the neonatologist is worried that this baby is going to throw a seizure anytime. And if you look at the history, mostly the family would tell you, हाँ जब से घर गया 2-3 सुसु किया है, potty तो जब से घर गया नहीं किया. So no urine output or very less urine output. No stool output is a common scenario that we see. Now, it can be worked upon in two ways, and I've taken two scenarios. One scenario is, again, unfortunately, this happens very commonly across our setups. So formula is added, and often families kind of get at times a very obvious thrashing, at times subtle hint of thrashing. Oh, why did you did not feel well, you did not feed well. Formula is added, and the moment formula is added, the child is like literally bacha chamak jata hai, the child starts gaining weight. And then what is it that the family goes through? Oh my God, I decided to breastfeed, and that is why this happened. Had I added formula, this would not have happened. But actually what happened, they did not get the skills. They did not get the latching skills. They did not get the assessment skills. So family is now in PTSD, post-traumatic stress disorder, and many babies who are born in the same family might be added something else because of this incident that happened. And mostly these babies will stay either on mixed feeds or on exclusive formula feeds. Another scenario, there is constant skilled guidance and support with breast milk expression. Supplementation strategies are taught, and even if formula is given, heaven forbid, parents are taught why this happened. Just a blanket statement of lactation failure is not there. And parents are also taught monitoring about signs of milk transfer, how to supplement using this express breast milk. And more often than not, these families would stick to exclusive breastfeeding because they realized, because troubleshooting was done for them. So how do we empower families? We can teach them skills of hand expression. If we do not have the time, again, we can have people who can teach families, because again, commonly, if you notice, what is the commonest method wherein milk supply is checked? Most of the healthcare providers would just squeeze the nipple to show the family whether milk is there or not. And that is what the family goes home and replicates at home. They squeeze. Again, teaching them patiently, letting them practice how to cup feed their baby. Cup feed is a term which we give to direct catory feeding, or some families do use nifty cups also. So again, this is not a tutorial on how to teach a family to cup feed. It is just to show that these are the things, the resources, they are available and they can be taught to the parents. So coming on to our last case of today, you see a family in OPD where baby is 3 weeks and not gaining weight, still at birth weight, rather baby is now at birth weight of 2.9 kgs, which was the birth weight. And this is with clothes. Mother says baby is hungry whole day. This is more or less similar to the previous case that we saw. And she keeps feeding the baby whole day. Now urine output is 6 to 7 per day. Here baby is passing 1 stool per day. Maternal nipples are sore but not grossly injured. And weight today is 3 kgs with clothes. So more or less 2.9 kgs. The baby is wearing single layer of clothes. Now, what is your impression? So again, we can discuss once the talk is over about this case, but read through these questions. What do you think? Everything is okay? Breastfed babies gain less weight, which is the common perception in our society? Or you feel mother has low milk supply? Or you feel baby is not latching or suckling well at breast? You can think either of these things based on whatever your experiences have been so far. If you're a lactation professional, in all probability, you might be thinking that baby is not latching and suckling well. But again, the question is, this is the majority of thing where what we are seeing. And these babies are often put into the category of not thriving, added on to formula. I've seen so many babies where the families were put for so many tests because the baby is not thriving. Because again, our knowledge is that baby is feeding well because the baby is passing 1 stool a day, baby is passing 6-7 urines a day. So why is the baby not gaining weight? More often than not, it is overlooked that baby is not passing adequate stools in a day. Mother is having sore nipples, and these are clues enough to understand that something is not going right somewhere. And if this family is not if their issues are not addressed right now, what we will find is within a few weeks, maternal milk supply because of secondary suppression will get inhibited. So quickly, the levels of breastfeeding support available in India, we have peer supporters. So we have many mom-to-mom support groups, which are mostly run by experienced moms who have some knowledge of breastfeeding support. Some of them do certain courses as well. And then the second level is healthcare team, which have some lactation trainings. So hospitals, when they apply for BFHI accreditation, they get some of their people trained. So they are the second level of support. Similarly, many doctors and nurses, many times they do lactation courses, so they can form the second level of support. Third level of support is trained lactation counselors. Like we have an excellent course in our community infant and young child feeding course, which is run by BPNI. Similarly, many courses run by BPNI Maharashtra. We have CLCs, we have CAPA certified people, we have ACLP by Begin Ed India, who are course partners of Association of Lactation Professionals India. And then we have IBCLCs, who are considered to be people who have under 1,000 hours of lactation training before they are, 500 hours of training in lactation and 1,000 hours of practice with the nursing diets to be eligible to give the exam. So when we look at all this, it's a good idea to understand who needs more support. Some people, as Dr. Swati said in the beginning, things go well for many people, but then things might not go for many people. And who are these people where we should either be giving anticipatory guidance, or who we should keep in our vision for more and constant support, or who we should refer, like primies with interventional birth, where there is a chance that baby might have get affected. Anyone with previous history of breastfeeding challenges, families with babies in NICU, multiple births, babies, moms with medical issues, history of nipple injuries, mastitis, breast abscess during this pregnancy or previous pregnancy. So these are some common categories who should be kept under observation and constantly who might need support. So that was my bit for today. The session is open to discussion. I hand over to you, Dr. Swati, and thank you for your patient listening.
Thank you, Dr. Shacchee. It was a very informative and practical talk. So I would like to invite the chairpersons to give their inputs. Professor Chellani?
Okay, yeah. So, Dr. Swati, thank you. Such a excellent talk, and thing you touched the very key issues for the prevention of the problems, as well as once the problem happens, then how to overcome these issues. I was thinking that I'll keep my comments reserved, but can you then answer some of the questions from the audience first? Because that would be nice, and then maybe we can discuss some of those issues later.
Right.
Yeah.
Right.
So, Divya has asked, ma'am, I want training as lactation consultant. Please guide regarding that. As of now, we don't have any other questions.
Right. So Divya, please go to the Association of Lactation Professionals India website. You'll type in Association of Lactation Professionals India, or go to the BPNI website, wherein you can find more information about the IYCF training. There are many online courses available, and it is good to know that no one becomes a lactation consultant straight away. And when you start learning about it, then start working with breastfeeding families. Once you have a certain amount of lactation education hours and hours of working with breastfeeding diets, you would be able to take up the IBLC exam, and then you can certify yourself as a lactation consultant. I hope that answered your question, Vivian.
So I would also like to answer for this question. The thing is, what is happening? Why so much of echo is coming?
Ma'am, are you logged in from 2 devices?
Huh?
Ma'am, are you logged in from 2 devices?
नहीं तो.
Maybe that's where.
There is another question.
I am also North India. I am looking after the training programs of BPNI. I am the director for that. So you can contact me. We will be planning soon for that training. And I will now see what is happening here.
So, Sachi, there is another question. Are drugs used for breast milk output really helpful?
That's a very good question, actually, and I'm glad someone asked this, because very commonly in the prescriptions that we see, the family goes, baby is dissatisfied, baby is not gaining weight. Very commonly, you get either some herbal supplements prescribed like Gallic, Lactair, Shatavari, and all that, or you have medicines prescribed. Dom, I think voices are coming back from the mics of other people. So I think everyone needs to mute. Yeah. So the drugs that are used, there is no systemic trial which says that drugs are actually helpful. If the correct management of breastfeeding, like latch support, effective suckling support, if they are helped with, most of the families would not need drugs. But once milk suppression has happened, some studies have shown the role of galactagogues. We have trials only on English medicines, which are domperidone and metoclopramide, which is perinom. So these drugs are used when suppression has happened. So like inducing lactation or relactation, wherever a mother has had suppressed lactation because of incorrect management of initial issues. And there also the role of skilled lactation support in helping achieve a good latch, in helping regularly express milk, in having the mother and baby lots of skin to skin, are more effective strategies than the drugs per se. And also drugs can only be prescribed by registered medical practitioners and not lactation professionals or people who do not have the degrees.
Sachi, there is one more question that these are the 31-weeker triplets, which is again a challenging problem, and there is a failure to thrive. So
right.
Still they can be managed on the breast milk, or they need some supplementation.
Right. So, sir, to answer everyone, there are case reports that babies can actually survive on breast milk alone. But again, the question here is the babies have failure to thrive. And I am presuming that this failure to thrive is maybe because the babies are not getting adequate nutrition. So how can we support this family? Some important strategies are that helping the mother with efficient drainage of breast, because 31 weekers would not be suckling efficiently, even if they are suckling a bit, because beyond 32 weeks, many times suckling, swallowing coordination also might not have come. So encouraging skin to skin contact, encouraging the mother to express, again based on her medical condition, how she is able to do it, helping arrange donor milk if that is an available option in that case scenario, especially preterm donor human milk. And also, like in discussion with the neonatologist, how we can add, sir, what's the term for that, fortifiers? How can we, is there availability of human milk fortifiers which are non-bovine in origin? Can we do something about it? So in consultation with the neonatologist who's working. And sometimes the strategies that are used is helping mother extract more hind milk, because that's richer in fat. In some Western countries, there is an option of doing crematocrit, as in they spin the milk and they take out the topmost layer, which is the fat collects at the top, and that's supplemented. And this is done with donor breast milk. So I can think of these strategies, although that would be a very challenging thing and would need teamwork between the family, the neonatologist, the lactation profession. So please, I would love your inputs here.
Thank you, Shacchee. First of all, Dr. Swati, let me tell you that I retired from Safdarjang Hospital only last year, and now currently I'm working as a scientist with the Society for Applied Studies, which does the randomized controlled trials at the community level, and also I am a WHO consultant for the implementation research, especially on my favorite topic of zero separation. So coming back to the Shacchee, your topic, actually, I was thinking that some of the key things, though which you touched, but I wanted to little elaborate on the preventive aspect. And those are some of the guidelines, actually, if we see why the lactation failure is happening, especially for the small and sick babies, and why these babies are not thriving so well in a community. If I see from the labor room or even before that, of course, antenatal sensitization, number key one. But second, with the cooperation of the obstetrician and nursing colleague in the labor room. Because we pediatrician and neonatologists feel that labor room is not our domain actually, but I feel that skin to skin contact in the first 1 hour, right in the labor room. And now many of the hospitals both in the private as well as in the Lakshya program in the government, they are allowing the companion there. So there is someone, and this first 1 hour skin to skin contact is very crucial to establish the breast milk support. And if we lose this opportunity, then we are going to have many problems. Then secondly, the problem which now in fact we are talking about is the moment the baby is sick, or for example even the baby is stable but the baby is separated from the moms, even when we see in the nurseries or in this. So when you keep the baby who is sick or who is low birth weight baby for assisted feeding inside the NICU and mom comes intermittently, mom is not allowing the baby to be onto the chest, and suddenly on the 4th and 5th day, you tell them that you give the exclusive breast milk feeding. And Shacchee, you in yourself, you said in your talk, first 1 week is very crucial. If I lose the first few days, it's not an on-off switch that breast milk production will go on. So I think next important message is, as far as possible, keep the baby and the mother together. I would say it's bedding in, not rooming in. Even the mother and baby should be together. They should be shifted from the labor room to the postnatal ward together. And there is a large chunk of our low birth weight babies, 1800 to 2500 gram. They are unnecessarily separated from the mother. The now WHO guidelines, which were released in 2022, says that start kangaroo mother care as early as possible. So low birth weight babies, they have a special issues on suckling, but once they are with the mother, the output really improves. So I think it is a cooperation of the obstetrician and pediatrician, very, very crucial, and nursing colleague right inside the birthing place. And Shacchee, you touched the role in the operation theatre. I think, and recently I visited Bangladesh, being consultant to the WHO for 4 countries. So I saw with the cooperation of the anesthetist, the baby has been put onto the mom's chest, right onto the OT table. And I saw myself the 2 hospitals, they are doing this practice. I think if we keep mother and baby together, then these problems would be less. But the problems, they do happen. So there comes again the role of the, the coordination and really is supporting the mothers by the lactation counselor. This lactation counselor can be pediatrician, can be obstetrician, nursing colleague, or the person who has got a extensive training in this lactation support, as Shacchee, you are one of them actually. So I think it is crucial that mother should be given proper environment and eco-culture. I feel the hospital should be the baby friendly, of course, but not as a lip service, but actually the practice of keeping the mother and baby together. And everybody talks about the promotion of the breast milk feeding. Wherever these small babies are really challenged, the question which came about the triplets, yes, there are case reports, but in practice it has been seen twins can be easily managed, right? But triplets, sometimes there will be a challenge, particularly those babies who have not suckled the breast actually. But still, if the mom and the baby are together, she expresses the milk, then I think this, what we now even term as predominant breast milk feeding. So if the baby is receiving more than 50% of the total output, so that can be encouraged, and keeping them together will definitely serve this. There is definitely no role of the lactogogues or the medication. These are more like a placebo. We have now systematic review which says that good lactation support and suckling is much more effective than these lactogogues. So I will stop the comments here. I will request Anita madam to talk, because I know as an obstetrician but a great counselor on this subject. So over to you, Anita.
मैम म्यूट हैं आप.
You are still muted, Dr. Anita.
Ma'am is unmuted, but somehow we are not able to hear her.
Yeah, there is some.
Am I audible now?
Yes, now it's, yeah.
Yes, ma'am. Now you're audible.
Audible? Okay.
Yes, ma'am.
So thank you, Shacchee, for such a wonderful and informative session. And in nutshell, we can say, actually, I've been a trainer recently, and we have divided, Dr. Chellani, this course of R into two. One for the hospital initiatives, just for breastfeeding, and the other is for the complement, the growth one. So it is now for 4 days only. We'll be doing it only on the institutional basis. So there, whenever I have gone, I have seen that one day I could start the day. I taught to the senior resident and everyone that it can be done. Cesarean babies can be put immediately on the breast, and they were really surprised. And when I showed them skillfully, they all made videos and they sent me, okay ma'am, we could do it, we could do it. So it's not difficult, as you said, it is happening. So it's not difficult if we know the skill how to make the baby attach. And secondly, if we want to divide for not thriving babies, it can be only 3 causes, as you also suggested. Like milk production, we have to look, and that is important. Milk production is only if it's high risk people we should identify during antenatal period. Then any breast problems we have to identify, primaries. So if we know that, and no separation from the baby and the mother at the time of delivery. So that is the milk production will only happen if there is first day the baby is with the mother, like Dr. Chellani said, skin to skin, and we start initiating within 1 hour. And second thing is the milk transfer to the baby. As you said, has to be, the second part is transfer. Whether the baby is preterm, naturally the strength is more he has to use, then we have to supplement, because the transfer is not going that much which much we want. So then attachment, latching, everything has to be taken care of the milk transfer. And the third thing which is important, what is the quality and quantity of milk which is going to the baby. So that again depends whether the baby has been seen with the clues. As we said, if the baby's clues are not told to the mother when the baby is hungry, the baby is crying, losing all the energies, how the baby will thrive? So we have to make mother understand that clues are really important. Start feeding as soon as the baby gives you the clues. And the demand has to be on the demand feeding, as much the baby wants to take. So this is in nutshell that if we take care of all these 3 things, the milk production, the transfer, and as well as the quality and quantity. Like we say, take from both the breast, but we are always giving the foremilk. So hind milk is not going. As you said, preterm we have to, if we have to improve the quality and the quantity we want to give less, then again we have to separate the hind milk and give it to the baby. So if we take care of these 3 things in not thriving babies, then I think they will be able to manage in a better way. So everything you covered, I can just summarize it that these are the important things which we have to look for. And we have doing this trainings. Anyone interested, they can be in contact with me. So in all North Delhi, in North India, I'll be in charge of the training cell.
Thank you, Dr. Anita. Are there any other questions from the people, so that Shacchee will be too happy to answer them?
So there are no questions in the chat box. If anyone wants to ask a question, they can raise a hand or speak up.
Yeah.
It was so clear, no questions. Huh?
Sir and ma'am, thank you for adding in your valuable inputs. Dr. Swati, hand over to you.
Yeah. So we have come to the conclusion of this session. And first, I congratulate Dr. Shacchee. You have very well proven that how far a skilled lactation support can go to ensure breastfeeding. And I thank our chairperson, Professor Chellani. Thank you for correcting, sir, and best wishes for your new role. And thank you, Anita Gupta, ma'am, for taking out valuable time and sharing your vast experience. Last but not the least, thank you, all the audience. And the recording of this session will soon be posted on the YouTube channel of BLKPediatricPractice.com, and we'll share the link also. And so goodbye for now. And next month, we'll come back with another interesting topic. Thank you, everyone.
Thank you, Dr. Swati. Thank you for the invite.
Thank you. Thank you, everyone. Ma'am, sir.